It's a pleasure to be presenting this information that I think should be of great interest to all of you. So what I will be talking about is how to integrate scientific evidence into best clinical practice. And we're going to start off with a background, the rationale for high-level disinfection of ultrasound probes. So what happened before we had evidence-based practice? Well, before that, health professionals relied on advice of more experienced colleagues. The advice was often taken at face value, their instincts, and what they were taught as students. We may wonder why the practice of bloodletting persisted for so long, especially when research in the 16th and 17th centuries exposed substantial errors. It continued to be based on traditional teaching rather than evidence-based research. But what will physicians think of our current medical practice 100 years from now? They may be astonished at our overuse of antibiotics or the way we reprocess ultrasound probes between patients. Evidence is subject to flaws of bias, experience that is, and what we learn as students can quickly become outdated. Relying on older, more knowledge colleagues as a sole source of information can provide dated, biased, and incorrect information. That's not to say that clinical experience is not important. In fact, it's a crucial part of the definition of evidence-based practice, which I'll abbreviate as EBP. However, rather than relying on clinical experience and decision-making only, healthcare professionals need to use a clinical experience together with other types of evidence-based information. So, why is evidence-based practice important? EBP is important because it aims to provide the most effective care that is available with the aim of improving patient outcomes. Patients expect to receive the most effective care based on the best available evidence. It promotes an attitude of inquiry in health professionals and starts us thinking about, why am I doing this way? Is the evidence that can guide me to do this in a more effective way? As health professionals and part of providing a professional service is ensuring that our practice is informed by the best available evidence. EBP also plays a role in ensuring that finite health resources are used wisely and that relevant evidence is considered when decisions are made about funding health services. So now let's turn to healthcare-associated infections, which are abbreviated as HAIs. Reducing ultrasound probe cross-infection risk can aid in reducing healthcare-associated infections. Evidence-based systems are used to prevent and control HAIs. In the United States, an estimated 5 to 10% of hospitalized patients will experience an HAI every year, resulting in substantial morbidity and mortality. The European Centers for Disease Prevention and Control reports an average prevalence of 7% in European countries, as you can see, quite similar to that in the United States. In a European multi-center study, the proportion of infected patients in an ICU can be as high as 51%, and most of these are healthcare associated. Approximately 30% of patients in an ICU are affected by at least one episode of healthcare-associated infection. This results in a longer stay in the ICU. With a longer stay in the ICU are more at risk since it's based on time. On average, the cumulative incidence of infection in adult high-risk patients is 17 episodes per 1,000 patient days. High frequency of infection is associated with the use of invasive devices such as central lines, urinary catheters, and ventilators. Reducing ultrasound probe cross-infection risk, as I said, can reduce HAIs. Prevention of HAIs is a top priority globally for different departments of health, and HAIs are a focus of multiple national and state reporting requirements and prevention initiatives in the United States and across the world. Up to 70% of HAIs are preventable using existing infection control practices, and this is a very important point that most of these infections are preventable. Infectious transmission occurs due to inadequate cleaning, inadequate selection and use of the disinfecting agent, and failure to follow recommended cleaning and disinfection procedures, and this refers specifically to probes that we're talking about. So, reducing ultrasound probes, again, can result in reducing HAIs. Patients are 41% more likely to have a positive bacterial culture 30 days after a transvaginal scan where the probe was low-level disinfected, and 26% more likely to be prescribed antibiotics, both suggesting, in fact, that the low-level disinfection led to infection, which led to antibiotics. MHRA alert released due to a patient death from hepatitis B infection due to improperly reprocessed transesophageal echocardiography probes. So here's an example of failure of proper cleaning and disinfection to lead to a serious infection. More than 80% of probe handles that are not disinfected had residual pathogens. Up to 10% of condoms and barrier sheaths that are used to help prevent contamination of the probe leak. Therefore, it's a critical point to know that their use does not replace the need for high-level disinfection. Up to 70% of ultrasound probes were found to be contaminated with human DNA and HPV DNA after disinfection with low-level wipes. Here are just some of the outbreaks associated with transesophageal ultrasound probes, and I'm not going to read all of these cases, but the top one in England, death of a patient due to hepatitis B may have been associated with failure to appropriately decontaminate the probe, even though there was a probe cover used. In Belgium, 42 patients were colonized or infected. Mortality rate was 40% among infected patients at a very large cost. Another example is a healthcare-associated outbreak of Legionella caused by contaminated transesophageal echocardiography. We have another example of an increased incidence of Enterobacter in a cardiovascular ward, again due to failure to properly disinfect transesophageal ultrasound probes. Going down, then you can see cases of Serratia marcescens, an outbreak of Pseudomonas aeruginosa. All of these were traced to improper use of contaminated ultrasound gel or improper disinfection of transesophageal ultrasound probes. And here are examples of problems and outbreaks related to improper disinfection or use of rectal ultrasound probes. Again, on the top, you can see an example of one patient affected by hepatitis C, another case of possible HIV transmission. Going down the list, you can see infections related to non-tuberculous mycobacteria, Pseudomonas cepacia, so an outbreak of Acinetobacter, and then Burkholderia. Again, a whole series of pathogens all related to the same problem, either use of non-sterile equipment or supplies such as non-sterile gel, or failure to perform adequate cleaning and high-level disinfection of an ultrasound probe. Now we go on to vaginal probes, the same issue. You can see here data from Hong Kong, France, Spain, in multiple different studies showing that when you, despite using a probe cover, when you use cleaning and only low-level disinfection, a number of those probes are positive, most importantly for human papillomavirus, a major cause of cervical cancer. But then you can see we have other problems as well, such as mycoplasma, Staph aureus, infection, or being found on the probes, again, despite appropriate probe covers and low-level disinfection. So again, we need to emphasize proper cleaning and high-level disinfection. Here is a computer model of how important and what type of risks this represents for an entire country if you use low-level disinfection on endocavity probes. So the goal of this simulation study was to model what would happen if you used only low-level disinfection in France. It was a stochastic Monte Carlo simulation. What were the results? HIV, we would have 40 new HIV infections each year in France by using only low-level disinfection. For other viral diseases, an enormous burden, meaning roughly between 1,600 and 15,000 infections of other viral diseases just in one country. Again, the conclusion, we need to follow guidelines such as the CDC for high-level disinfection of all ultrasound probes. So as we talk about the differences between what high-level disinfection accomplishes, this little schematic demonstrates that. So for sterilization, that is defined as the complete elimination of all possible microbes. High-level disinfection will eliminate all microbes except for high numbers of spores. It will eliminate low numbers, but not high numbers. But it will kill off all the mycobacteria, all the viruses, enveloped and non-enveloped, particularly important for rectal and vaginal probes as HPV. It will eliminate all the fungi and all the bacteria. So here we have the classic Spalding scheme, which bases what type of disinfection sterilization you do on how the item is used. If the item is used to contact sterile tissue or an implant like a cardiac pacemaker, it should be sterilized. That kills everything. If the item is used to touch a mucous membrane or non-intact skin, then all you need to do is high-level disinfection, but you must do high-level disinfection, which will eliminate everything except high numbers of spores. If the item touches intact skin, then you just need to do low-level disinfection that will kill vegetative bacteria, some fungi, and envelope viruses, but would not kill mycobacteria, spores, and may not kill non-envelope viruses. So this is the scheme that's widely used around the world to determine what type of sterilization disinfection is used, should be used based on the use of a device. And probes are semi-critical devices because they touch mucous membranes. And again, this is just another way of looking at what we just said, going from non-critical to semi-critical to critical. Non-critical items touch intact skin, and therefore we only need low-level disinfection. Semi-critical items contact non-intact skin, such as a burn, a wound, or a mucous membrane. There, it's critical to use high-level disinfection that eliminates everything except very large numbers of spores. Critical would be contact with sterile tissue, body fluids, bloodstream, such as an implant or an intravenous catheter, and those need to be sterile, completely devoid of any microbial pathogens. So what has the global response been with an increase in publications of guidelines? So we have multiple guidelines from multiple countries that appropriately follow the Spalding classification. That is, ultrasound probes must receive high-level disinfection. Of course, the CDC Guideline, of which I was a co-author, came out in 2008. It's being revised now. But then you can see similar guidelines from many, many other countries. You can see the BMUS guideline in England, the Hospital Infection Society guideline, one in 2017, 2018, therefore several years old now. But you can also see guidelines from Canada, Australia, Germany, France, many of the countries in Europe. But not only them, but you have countries such as Saudi Arabia, the World Federation of Ultrasound, and others, all agreeing that probes need to be high-level disinfected. Now I'm going to discuss the rationale for high-level disinfection of endocavity probes based on the best available evidence. First of all, we need to assess, is the published research of good quality? So not everything you read in any journal that's sent to you is in fact of good quality. So not all research should inform clinical decision-making. Therefore, you need to critically read every single article and use that to inform your clinical decision-making. There are three aspects of evidence you need to look at. Validity. So is the article accurate and can you trust it? Impact. Are the results clinically important? And applicability, that is, based on what they said, is it in fact feasible and possible for you to translate that to your patient? EBP hierarchies rank study types based on the rigor, strength, and precision of their research methods, and different hierarchies exist for different question types. And some experts will disagree on the exact ranking of the evidence hierarchies, but here is one for you to the right. We'll talk more about that in a minute. And essentially what you see at the top are systematic reviews, where they use a defined method to review all the available literature that's best informed on appropriate, well-designed clinical trials. But that should also be based on appropriate non-human research in laboratories and others. Certainly we do that for drugs. We want to know pharmacokinetics. For disinfectants, we want to know, based on the laboratory, how effectively it kills, and the disinfecting devices are the same. So again, here is the hierarchy. Again, at the top of the hierarchy are systematic reviews that would review all the relevant clinical and non-clinical evidence and studies. So for clinical studies, the best studies, of course, are randomized clinical trials. Less valid are cohort studies, although if they're well-designed, they can be very informative. And underneath that is case control studies. And below that is expert opinion. As a separate hierarchy, which people have not really made, are well-designed basic science studies. What we've learned in the laboratory, as I've already mentioned, for drugs, things like how the microbe is killed and pharmacokinetics. For disinfection devices, you obviously want data. Does that device kill the pathogens of interest, and does it do so in a realistic time frame? Now, what is the rationale? We're going to move on to the rationale for high-level disinfection of endocavity probes and give you some actual data. So first, we have to demonstrate the efficacy and effectiveness of a disinfectant or device for disinfection. Efficacy means a study that's done under ideal circumstances. In a clinical trial, that's a randomized clinical trial. Effectiveness means how does it work in real life situations? So we want to demonstrate that a disinfectant or a device inactivates microbes that you would inoculate onto a surface of medical devices. And then the key thing for the disinfectant or the device is the antimicrobial spectrum. What does it kill? Obviously, for vaginal and rectal probes, it must disinfect things such as gonorrhea, syphilis, HIV, sexually transmitted agents, but certainly also HPV. The speed, how quickly does it work? We want a disinfectant or a device to work in seconds or at most a few minutes. We don't want disinfectants and devices to take minutes to hours to work. And then how many logs does it kill, which is part of the definition of high-level disinfection. And we then move on to, we want to not put it on an artificial surface. We want to show that this disinfectant device will actually inactivate microbes on actual healthcare environmental surfaces or medical devices after use. So not just laboratory, but we want to prove that on real life ultrasound probes, a disinfectant or a device works. And ultimately, we would like to show that the disinfectant or device will reduce healthcare-associated infections. That will require a large clinical trial, although in the place of very large trials, because they're expensive, difficult, and time-consuming, modeling can be used to provide evidence of effectiveness. So let's start off first. What are we aiming for? What's the ideal disinfectant or device? Broad spectrum, that is, kills all the relevant microbes. Fast acting, we already mentioned. Non-toxic, so it's not dangerous to the user, the patients, or the visitors there. In addition to not harming people, we would like it to be safe for the environment. It needs to be compatible with the device you're using and not damage or degrade the plastic metal that the device is made of. It should be simple to use, ideally, just for a device, just put it in, push a button, and you're done. Obviously, disinfectants are a little more difficult because they're not really easy to use. You have to have contact with the disinfectant with every surface. There should be a means of actually validating that your device or your disinfectant really is working. Acceptable odor, color are important. And then finally, everything being equal, you would like to use the most cost-effective method. So, what technologies do we have for high-level disinfection of endocavity ultrasound probes? We have ultraviolet light, which we'll abbreviate as UV. The advantage for this, of course, is it's totally chemical-free and perfectly safe for the environment. We also have hydrogen peroxide mist, and this is used as a 35% hydrogen peroxide. And this is a chemical agent, much like a chemical disinfectant, but in this case, it's a mist that would coat the item. So let's talk and focus first on ultraviolet light here. Ultraviolet light is a high-level disinfectant as the particles and waves are reflected from the walls of the chamber to cover the surface of the probe. And this is done at a germicidal wavelength of 254 nanometers. So at this wavelength, the energy of the photons penetrates cell walls of microorganisms, all microorganisms. It's absorbed by DNA, RNA, and the proteins, essentially destroying them and leaving them unable to perform their cellular functions, and therefore that pathogen is no longer capable of causing human infection. Ultraviolet light is used widely in a variety of different ways in hospitals and medical facilities. It's used for disinfection of water to prevent Legionella. It's used in disinfection of air in either operating rooms to purify the air or to prevent transmission of TB. It's widely used for surfaces. So when a patient with a multi-drug resistant pathogen leaves the hospital room, it's used to disinfect the hospital room. It's used for disinfection of hearing aids. And these are only some of the many uses well established of ultraviolet light. Well, here was a study about that looked at the ability of ultraviolet light, and here we're saying ultraviolet light C, which is that germicidal wavelength I've already mentioned, to disinfect intentionally contaminated anesthesia probes. 15 probes were exposed to non-sterile ultrasound gel, and then not only in the gel, they put a large inoculum containing known pathogens, Staph aureus, E. coli, Enterococcus, And then they left the gel on. They didn't just immediately disinfect it. They let it dry for a while. All of these things making it more difficult to disinfect. The probes were wiped dry with a paper to remove the gel, and they were wiped repeatedly until the gel was visibly removed. And then they were wiped with a disinfectant impregnated paper. The probes were placed in a UVC decontamination chamber by Germatech and exposed for only 90 seconds. Before UV exposure, all probes were contaminated. After UV exposure, all the probes were disinfected. So there we have demonstration that the UVC was effective in eliminating disinfection. Need to review research references used in research papers. Are they relevant or do they add bias? For example, the infection prevention control of ultrasound, a guidance here that's listed here. The guidelines reference to a research paper talks about room disinfection and compares room disinfection processes and the methods to ultrasound probes reprocessing. This is not a fair comparison. It's apples and oranges, and it adds bias. Hydrogen peroxide vapor or UV light for room disinfection has an entirely different purpose and methods compared to ultrasound probe reprocessing for probes. And so the ultrasound probe reprocessing disinfection method is delivered in a very controlled environment, a closed environment where distances are not measured in meters, but they're measured in millimeters or centimeters. And the intensity, since intensity falls off as a square of distance, is totally different. So one can't look at the data for disinfection of surfaces and make any conclusions about the use of closed area for disinfecting probes, and the reverse is true. The really two need to be viewed. The data needs to be reviewed separately, analyzed separately. Well, has the correct research methodology been used? For example, in the Munster article, the study described in this article is clearly invalid from a scientific viewpoint. While all studies on disinfection systems, notably ultrasound probes, are done with quantitative microbiologic analysis, meaning you actually count the killing or elimination. The discussed study only used a quantitative method, yes, no, which is often done in pharmaceutical research, but is invalid for the evaluation of semi-critical medical devices. The discussed study found more contamination after disinfection than before disinfection, which could have really no basis in science. This alone shows that the study design was inappropriate and did not have scientific value. In some cases in our study, bacteria, they said, were found in the second swab taken after disinfection, which were not found in the first swab before disinfection. So this tells you that somehow in their methods, they're actually contaminating the probes. Certainly a disinfectant, one could argue about how effective certain disinfectants or devices are, but you should never find higher numbers after disinfection than before, unless in your scientific method, you're actually contaminating the device. So this study has fatal flaws.